Hi, my name is Cherise Berry, and I'm an Associate Professor of Surgery at New York University Grossman School of Medicine and the Associate Trauma Medical Director at Bellevue Hospital Center here in Manhattan.
Hi, my name is Jim Coyne. I'm a Health and Life Sciences Cloud Specialist with Onix.
Our talk today is entitled, Are There Racial, Ethnic, Gender Disparities in the New York State Pre-Hospital Trauma System? So I want to start by highlighting an article that was published in the American College of Surgeons Bulletin a few months ago. Dr. Jamie Coleman is a trauma and acute care surgeon in Denver. Her husband is African American and was involved in a high-speed motor vehicle collision in December. He was transported to the nearest hospital where he received a visual exam. He did not receive IV fluids, an IV, an ultrasound, x-rays, CAT scans, or labs prior to the decision to discharge him home. And as she states, my mind was reeling, unsure of how basic advanced trauma life support treatment was skipped, unsure how any physician could think that it was okay to not perform an adequate workup. So our objectives for this talk include a background, reviewing the New York State 405 state regulations for data and quality improvement, identifying some of the data challenges within the current New York State trauma system, discussing the significance and relevance of enhancing the current system, and then proposing a solution to the current data challenges to improve our trauma system and improve patient outcomes. So traumatic injury accounts for nearly half of all deaths for Americans under the age of 46. Each year, about 29 million people are treated in emergency departments for trauma across the nation. Of those who are injured, about 2.8 million are hospitalized, and nearly 200,000 Americans lose their lives to trauma each year. Per the CDC, injuries account for about 60% of all deaths among people ages 1 through 44 years of age in the United States. That's more deaths than non-communicable diseases and infectious diseases combined. And, injuries cost the nation about $671 billion. That's $214 billion for fatal injuries, and non-fatal injuries account for about $447 billion. So studies really estimate that 20% of civilian deaths are potentially survivable with 40,000 lives saved per year. And there's a national movement to achieve zero preventable deaths after injury and to minimize trauma-related disability by creating a national trauma system as described in the National Academies of Science, Engineering, and Medicine report. And trauma centers and organized trauma systems, including pre-hospital trauma triage criteria and transport plans, have been shown to significantly decrease mortality for injured patients. And transport by EMS to definitive care facilities, which we define as American College of Surgeons verified level 1 and level 2 trauma centers, is really associated with a significant reduction in preventable deaths and injured-related mortality. But does every injured patient get transported to a trauma center? Are there disparities in access to trauma centers? So one study examined the geographic access to trauma care by race, ethnicity, and really sought to determine whether residential segregation and neighborhood poverty are associated with disparities in Chicago, Los Angeles, and New York City. And they found that Black majority census areas are more likely than white majority areas to be located within a trauma desert. And a trauma desert is really defined as patients being injured more than 5 miles away from a trauma center. So after adjusting for poverty and race-poverty interaction effects, a similar finding was noted in New York City. And with disparities existing in access to trauma centers, are there disparities in transport to trauma centers? So we know that here in New York City, about 200 trauma patients per year are transported to Bellevue Hospital Center, which is one of 2 level 1 trauma centers in Manhattan. However, the total number of trauma patients transported to non-trauma centers within New York is really unknown. And the racial, ethnic, gender disparities in the transported trauma patients to non-trauma centers within New York State is also unknown. So per New York State law, we are mandated to analyze regional and state trauma data quarterly for quality improvement and quality assurance of the trauma system. And one of the issues that we face is that regional trauma systems within New York really just don't exist. The regional trauma data for quality assurance and quality improvement does not exist. And because of this, our last annual New York State Trauma State Report was from January 1st, 2014 to December 31st, 2015. That's nearly 7 years ago. And because of this, we have been unable to perform routine analysis of regional trauma data and to submit the quarterly reports as mandated by state law. We've been unable to identify the number of trauma patients transported to non-trauma centers in the state. And we've been unable to make quality improvement recommendations based on current data. And the significance of this is really about patient care. As we stated earlier, transport by EMS to definitive care trauma centers is associated with a significant reduction in preventable deaths and injury-related mortality. And access to current data really is needed to improve the trauma system. Data drives change and quality improvement, which ultimately improves patient care and outcomes. And here's the solution. So we decided to partner with Google and Onix in determining a solution for the challenges for the state. And part of the solution involves taking the data, accessing it, preparing it, storing it, cleansing it, processing it through BigQuery, and then visualizing the data using Looker to develop these reports and dashboards in near real time. So the conceptual framework for the New York State data includes the following. So every EMS patient encounter within New York State gets uploaded to a data repository. And from this data repository, we can then select trauma-specific variables such as demographics, vital signs, types of injuries, and whether or not they've been transported to a trauma center versus a non-trauma center. We can then export that data daily into BigQuery for processing, cleansing, and removing duplicates. Then we can export that data to Looker for analytics and dashboard, all in near real time. And so we decided to pilot this concept utilizing the national EMS data within the East region, which incorporates 12 states plus Washington, D.C. We look specifically at the 2018 and 2019 data. So we ingested that data, transformed the data, removed the duplicates, flattened the data, cleansed the data, did a quality check, and then validated the data. From here, we were able to then visualize that data through Looker into dashboards, which included geospatial analyses, response times, and the trauma reports that we had talked about earlier. And one of the most important aspects of this solution is the data de-identification and HIPAA compliance. So the Google Cloud Healthcare Application Programming Interface, or the API, detects sensitive data such as protected health information, and then uses a de-identification transformation at the dataset level to mask, delete, or otherwise obscure the data to maintain HIPAA compliance and confidentiality. So here is an example of how we were not only able to visualize this data, but we were also able to generate the same 2014 to 2015 trauma reports, except with this solution, the reports would reflect the most current data in near real time. And you can visualize that data with charts, graphs, pie charts, tables. And what we found in analyzing this data is that we actually did find gender disparities. In fact, among all critically injured women transported to trauma centers, 50.4% were transported to trauma centers compared with about 60.4% of critically injured men. And on logistic regression analysis, critically injured women were 21% less likely to be taken to a trauma center compared with men. And that result carried out with patients that also had unstable vital signs. And so this solution was web-based. It's in near real time. We could look at the data by state, by region, by county, and we can do geospatial analyses. So now I'd like to turn it over to my colleague, Jim, to go into more details of this solution. Jim?
So when looking to answer these big questions with analytics, you often need to start with what data are you looking at? What are the sources? What's the infrastructure? Really a broad range of questions and concerns that can come up. With the Onix Analytics Modernization Program, we help you evaluate all of these. With Dr. Berry, we were able to work with data that she was able to acquire and use systems that are all cloud native to present this proof of concept that will allow the state of New York to start to understand where the value could come into place if they were to modernize a lot of their real-time data reporting infrastructure. So where we start is to understand what is that value of the data, what is it going to take to get to the point where you can reach the predictive analytics that really the cloud and a lot of these advanced analytics solutions offer. And we have a program that would take you step by step. And with Dr. Berry, we were able to do this in a relatively short period of time to emphasize where the value could come into play and then get to that future state vision that'll allow you not only to look back at what happened last year, but take the aggregation of all that data and use what the cloud and what Google has in place to start making insights on what the future has to hold and what sort of decisions can be made so that in the future we see more of equity and equality when it comes to care within EMS in the state of New York and maybe even beyond. So more specifically, when you start working with the data sources for this particular project, we looked at de-identified zip code level data that allowed us to provide that overlay of where the patients were coming from, where they were transported to. And as you work with that data, you start to break apart, munge, a lot of different terms on how the data science works, but we try to keep it simple as far as bringing it into a drop zone that then from that point can be segmented and allow the right users to have access to it. And as you move further through this chart, you see you eventually get to a place where you have your processed data that can be consumed. And as Dr. Berry was showing earlier, you have that looker interface that allows you to query your data in real time, build specific looks to answer specific questions, and meanwhile knowing that the underlying data infrastructure can continually be updated and then eventually reach that point where you can have near real-time or even real-time data reach all the way to the analytics layer that can be tied into other systems in the future. And again, it all speaks to the versatility what the cloud enables folks to do with their data today that may not have even have been possible just a few years ago. With the Onix Population Health Solutions, we work with Capsco Health that have pre-built solutions in Google Cloud today, really a first end-to-end population health solution, and use that experience to bring the value to this project with Dr. Berry. We were able to work with their data scientists who have experience not only in the science of data, but in the science of healthcare. And even an EMS official that was part of the project was able to add insights and data quality metrics and so on. And what do we mean about population health? In many ways, this is an example. How can we take the data that is available within all these disparate sources and start to make insights to affect positive change in healthcare? And with our population health solution, we integrate EHR, EMR data, allow the de-identification process to take place so that you can extract the insights and lead to the savings not only in time for the ability to see what is actually going on within your environments, whether you're a payer, provider, state agency, and so on, but it'll drive that 99% accuracy as well with the natural language processing, and again, built on the world-class state-of-the-art services of Google Cloud, and including Looker. And to go back to the use case that we were looking at with Dr. Berry, and looking at these data sources, you can start to see how the solution comes to fruition, where you leverage Google Cloud services such as storage, BigQuery, their AI platform, AI and ML, and then start to build out those analytics and visualizations layers in Looker. And within Looker, be able to segment looking at the specific demographic data, start to look at regional hotspots, and then even start to see where the trauma center and non-trauma center analytics are playing into bear to answer that question. Are there disparities in how this transportation process works? And then from that, most importantly, the ability to deliver those actionable insights. So to get quicker to what is going on in near real time, rather than looking at data that may be 5, 6, 7 years old, be able to intercede and develop communication campaigns, even steerage of patients to the right treatment centers, and the tracking that this solution provides would allow that change to be seen in real time. That'll make it a lot simpler to make the points that I suppose would need to be made for policy to change and for the equity and equality to be part of this system.
Thank you, Jim. And this really takes us to the significance of this project. It's really all about improving patient care. We want to improve patient care and patient outcomes within New York State. We want to improve the New York State and regional trauma systems and really become a model for other state trauma and regional systems. And not just specific to trauma, but other emergency medical services such as stroke and STEMI. This is our call to action. Even a 5% reduction in trauma deaths and economic burden would mean 10,000 lives and $33 billion saved every single year. Thank you.